in pain and we don't give. So they should learn. So all these training modules are ready, and physiotherapists already available in the district hospital. How to extrapolate their training in terms of cancer patients. This we have to. So minimum resources. Say how we can manage best all these things. We have to teach and train doctors and nurses. And last thing, which we have to teach them, soft skill, how to communicate empathetically, because when patient isn't coming with whether chemotherapy or radiotherapy or oncological emergencies, they need good communication, they need honest information, and they need realistic hope. So how to give in various stages of the disease, this we have to teach to all the doctors and nurses available in the district hospital. Thank you very much.
Thank you, ma'am. And now we move on to Dr. Anurag Srivastava, who has remained as a professor and head of Department of Surgical Disciplines in All India Institute of Medical Science, New Delhi. Sir, while we are embarking on this journey, with your vast experience, can you please tell us what would be the necessary equipments which DCCC should have for chemotherapy? For example, the infusion pumps and patient monitoring, because when we are providing chemotherapy, we do not expect a smooth journey all the time. So there could be complications. So how do we equip these DCCCs, and what could be the fund requirements based on the costing? Based on your experience, sir, Dr. Srivastava, could you please share your thoughts?
Yeah, sure. Thank you. So I'll talk about the infrastructure and the equipment required for the daycare cancer centers. So the services that we will provide in the daycare centers will be chemotherapy, radiotherapy, if possible, if we have the radiation machine, palliative and supportive care, and public education and screening. So regarding the patient care infrastructure, we should have a spacious treatment areas where patient can have comfortable room for sitting and have an accommodating environment. They should have private consultation rooms where patient can be seen with confidentiality and full privacy. We should have relaxing waiting areas, again, for making the patients and reassuring them with comfort. Regarding chemotherapy administration, we should have a large room for daycare chemotherapy space. Depending on the number of patients we are getting, we should have 10 to 20 trolleys. There are specially designed trolleys available, patient trolley beds for therapy, where we can reclining head or foot depending on the need, and we have the drip stands attached to the same trolley. And so 10 to 20 trolleys. Nurses and doctors workstation should be available, at least one. A store for keeping drugs and intravenous fluids, at least one. Locker for controlled drugs, as Madam Dr. Bhatnagar said, morphine and fentanyl, other controlled drugs, there should be locker for at least one locker. Hand washing sinks, at least 2 sinks, and at least 2 toilets, one for the staff and one for the patient. So this is about the chemotherapy space. Regarding radiation therapy, if you have the radiation facility in your daycare center, and some centers can have, if they have a large population of cancer patients, at least one linear accelerator and a brachytherapy machine, an operation theater for brachytherapy, a room for radiation planning, one room for radiotherapist, and one room for radiation physicist, where they can sit and plan the patients. Regarding the medical equipment need, we'll need one radiotherapy machine if you are planning radiotherapy in the center, one CT scanner, one ultrasound scanner, and digital mammography machine, at least one, magnetic resonance imaging scanner, at least one, and laboratory equipment for blood cell counting, and autoanalyzer for doing the necessary biochemistry before and after chemotherapy. Regarding equipment for cytology, if we have the site doing FNAC or pap smear cytology, should be equipment for doing the cytology slide staining and histology preparation if you are taking some biopsies. Equipment for HPV testing. In many centers now, the WHO and experts like Dr. Nirja Batla are recommending HPV testing for cervical smearing, not pap smear, not VIA. So facility for HPV testing should be there. ECG and echocardiogram machines because many chemotherapies are cardiotoxic. So we need at least one ECG machine, and echocardiogram machine will be helpful, and a place for keeping laminar airflow chamber for preparing drugs. So the current recommendation is that we should prepare all the drugs within that laminar airflow to keep sterility. So at least one laminar airflow chamber should be available. Regarding patient monitoring, because these are very sick patients, so we need some monitoring equipment like pulse oximeter, maybe 10 to 20, depending on number of patients, multi-channel monitors for keeping blood pressure, heart rate, SpO2, respiration, and ECG recording, at least 10 or 20, depending on number of patients, blood pressure monitors, at least 10, body weight recording machines, about 2, and height measurements, about 2, because we need to calculate the BMI, and drugs are calculated based on the square meter of the surface area. So height and weight measurement machines. Regarding other comfortable seating arrangement for patients and relatives, a place where some refreshments, etc., can be provided, drinking water, Wi-Fi facility, and clean toilets should also be provided. Regarding the post-treatment and follow-up patients, we should have at least 1 or 2 rooms for clinical examination. If facilities can be provided, we can have a yoga and pranayama meditation, as Honorable Prime Minister Sir has just emphasized the need for yoga and pranayama incorporating into healthcare facilities, and dietitian room for giving advice regarding the special diets, clinical psychologist and genetic counselor rooms if we have the facility. A tobacco cessation clinic must be there. So a room for tobacco cessation and counseling, and patient support group staff like Indian Cancer Society and other cancer Sahyog group. So patient support care room, at least 1. And as Honorable Prime Minister suggested, that we should have AI-driven follow-up and AI-driven patient education, not only for that patient, but also for prevention of recurrence and cancer in the family members. So we should have a room for IT tools and space for IT personnel, database or computers, and room for medical records. So this is in short that I have to say about infrastructure and equipment. Thank you.
Thank you very much, sir. Thank you for sharing your thoughts.
Thank you, sir. Now I want to ask from Prasant, Professor Prasant from JIPMEP, about the medicine requirement and strategy for effective medicine chain management.
Thank you very much. So in terms of the
Your voice is not clear, probably.
Find them in 4.
Your voice is not clear.
Therapy.
Mr. Prashant, your voice is not clear. It is echoing.
Is it better now?
Yeah, it is better now.
Okay. Okay. Yeah. So I'll just start again. So in terms of the drugs which are required in daycare centers, we can classify them as 4 groups. One is the drugs required for the conventional chemotherapy, for supportive treatment along with the chemotherapy, drugs for the management of complications, and certain drugs which were required for the emergency purposes. So conventional chemotherapy agents, depending on what kind of cancers the particular center is planning to service to, at least it should have minimum drugs which are required for cancers of the breast, head and neck cancers, carcinoma cervix, lung cancer, sarcomas, because these are the common cancers that are usually treated in any daycare center. So these common drugs must be available. Of course, whenever we are giving chemotherapy drugs, we also need drugs to prevent reactions like steroids. We need drugs to prevent nausea and vomiting, including some oral tablets which the patients need to take home and take it for the next 2-3 days. And also, there should be also some oral chemotherapy agents like cyclophosphamide or etoposide, because these are used for some palliative treatment. So when some patients are on palliative care, they should not be having to travel to the main center for that. So they should also be available. In addition to that, there should be, of course, drugs for the management of complications. This is very important because the commonest complication of any chemotherapy which is significant is febrile neutropenia and infections. So to take care of this, when the patients do come back, we should have antibiotics available. So certain intravenous antibiotics like cephalosporins, and if possible, some access to carbapinams and vancomycin, but that is perfectly optional. But at least the first line antibiotic should be available. This is not very expensive and can be administered at any center. There should also be definitely a capability to admit at least on an emergency basis for 1 day or 2 days for some observation, some IV fluids to start the antibiotics for some of these patients at least who may be unstable when they come in, the diarrhea, vomiting, etc. So that should also be available. The emergency drugs which should be available during the infusion of chemotherapy, because sometimes we can get hypersensitivity. So some drugs like hydrocortisone, antihistaminics, adrenaline to manage the absolute emergencies which might occur when we are doing this daycare center. So this should be available. It can be tailored according to the needs of each center. With respect to the second problem, that is the supply chain. So important to have a system for constant availability. So any district center should have some kind of a real-time tracking of drug inventory, which is done on a daily basis, identify which drugs are going down, and have some cutoffs that below this level we order more. And some system for procurement, possibly some kind of an SOP should be there, either from the local hospital itself, or is it going to tie up with some higher tertiary center from where the drugs can be sent down to the center. So this process must be established, because once a person starts on chemotherapy, we cannot say when they come for the second cycle or third cycle, this drug is not available, that drug is not available. So this system must also be established for all the other drugs that we discussed about earlier. So that's what I have to say. Thank you very much.
Thank you, Prashant.
Thank you. And now we would like to come to Dr. Umesh Mahans Sethi, who is the director of Homi Bhabha Cancer Hospital at Visakhapatnam. Sir, we know now that we are going to train the regular physician or the pediatrician and MBBS doctors for chemotherapy. So it is not going to be easy task. So we need to develop certain protocols, the standard treatment guidelines. And how do you envisage developing these protocols, the standard treatment guidelines, and in case of need, how do we link them through telemedicine with specialists and super specialists sitting in tertiary care institutes across the country? Can you share your thoughts, Doctor?
Thank you. At the outset, I'm privileged to be part of this panel discussion. I belong to Tata Memorial Center family, and as you know, we do venture into a lot of these community programs. And at Visakhapatnam, we are fortunate to have a Tata Memorial Center unit where we are actively working with the Ministry of Health, AP State, where we have started these activities. And one of the major success stories for us in this region is that we have a venture called as National Cancer Grid, which is run by Tata Memorial Center. But we have a state chapter of National Cancer Grid in Andhra Pradesh, where all the medical colleges and cancer hospitals who are treating cancer patients in Andhra Pradesh are part of the members. And through this, we have integrated a lot of activities towards a comprehensive cancer care map for Andhra Pradesh. And through this venture, the state government did involve training 12 district hospital staff for daycare chemotherapy. And we were one of the centers for training. And during that, we developed a training module for a physician, as well as a surgeon and a pediatrician, a nurse, and a pharmacist about a training module which lasts only around 2 weeks, which includes both theory and practicals, pre and post test evaluation. And most important is we have made a referral pathways through which patients could be given chemotherapy at daycare was defined in the training module. This was done in 2024. The updates we'll probably get it from more from State Health Department. Having said that, through the National Cancer Grid, we have integrated a lot of things which have more or less streamlined in the Andhra Pradesh state for comprehensive cancer care. Number one, they have adopted the National Cancer Grid treatment guidelines, which are similar to ICMR guidelines. And every patient treated in Andhra Pradesh state under the scheme is only treated according to the guidelines which are applicable to Indian setting. And based on that, in that guidelines, we also have defined which are the common chemotherapy schedules which can be offered in these schemes. So based on those common chemotherapy schedules, we have classified them into low risk, high risk chemotherapy schedules. And for low risk, as of today in the training module, we have mentioned that the cancer patient will receive first cycle of chemotherapy in the designated comprehensive cancer care. During the first chemo, there will be a virtual tumor board with the hub and spoke model where the spoke will be defined that this is a patient has received this chemotherapy and there are no reactions. So this patient would be suitable for taking chemotherapy, subsequent chemotherapies in a district hospital where that person has been trained. Secondly, through this NCG activity, we also have weekly virtual tumor boards where difficult cases, difficult problems are discussed so that we can troubleshoot the issues remotely rather than patient being shunted from the rural background to the Apex Center. Having said that, from here we want to move forward, as other panelists have mentioned from various states, that most of the palliative chemotherapies which are being offered today, because 80% of the patients do qualify for palliative chemotherapy subsequently. This needs to be decentralized so that the comprehensive cancer care centers which are available in sparse can be effectively used for treating common cancers. So with these ventures, we hope that the vision of this budget 2025-26, where daycare chemotherapies can be decentralized, and if that can be done effectively, maybe the Apex cancer centers can take more role in trying to develop other pillars of cancer treatment, which are very, very important and essential. Thank you very much.
Thank you, Dr. Umesh.
Thank you, Doctor. Now, next panelist is Ms. Jyotsna Govil, Chairperson, Indian Cancer Society, Delhi. Madam, I want to know about the, from patient point of view, role of counseling services and its potential impact on the treatment adherence and patient well-being. Can you elaborate on this?
Good afternoon, everybody, and thank you for giving us the opportunity to voice the patient concern. We are an NGO, and so we work under several constraints, but we have built up a very good network of services by listening to the patients. So you have mentioned counseling. We call it Sahyog. We are not leading, we are not following, we are hand-holding and taking them along with us. With this, it is important that we create physical space where we can talk to the patients, keep an eye contact, and give them information not only about the disease, but also about all the other factors around the disease, which may be financial constraints, which may be sometimes a legal question, certainly diet, nutrition, and caregiving, so that the family is involved in patient care. Now, all this is a little difficult to do at long distance, but we believe that we have address that issue in our own way by creating an app. We call that app Rise Against Cancer. Last year, we have got 4 cancers covered, and this app is available in 5 different languages. So it is there in English, in Hindi, in Bangla, in Marathi, and in Kannada. Anyone with a phone can access it in Android or in iOS models. We talk about many things. Compliance to treatment is one of them, because without that compliance, the treatment goes off rails. We also talk about feedback from the patient because that is very important to us. We want to know how the patient reacts to the hospital, to the treatment. Are they aware that their cancer began outside the hospital? It will end outside the hospital. So are they prepared for it? Have they made financial provision? We talk about inclusion for marriages, for education, but who talks about financial issues where illness is concerned? So all these things are covered by us. What we can do for you, sir and madam, is that we can make this available not merely in the app that is already there, but by creating modules which you can play in the daycare centers. We are already on radio once a week because that's what we can afford. But with your help, perhaps we can take it to other areas with medium wave coverage and give all this information across the country to anyone. Again, we can do it in many languages. Somebody spoke of 24 languages this morning. I don't know, we're not that ambitious. We've got 5 now. Maybe there'll be another 2 or 3 in the next year, and so on and so forth. Dr. Swasti Charan asked me how we build trust, how we work with other stakeholders. Well, our primary stakeholder is the patient. So we listen to the patient. We see our primary task as building trust within the patient community. We offer them screening services, and even before that, we offer them cancer awareness and education. We go to schools and colleges, we do a lot of physical legwork, but we also use the digital medium because we realize that we need a voice multiplier and we can't be everywhere. All our workers are volunteers, so building trust is relatively a simpler issue for us than anybody who comes with a commercial or other interest. So trust is something that we are very particular about. We ensure that we are trained well first before we take information out to others. So we have our program on the SWAM platform of the Ministry of HRD. Again, it is free of cost. It is in English, in Hindi and Punjabi.
नमस्कार नमस्कार। अरे वो ना मुझे वहां जाना है, महाराज जी आ रहे हैं, महाराज योगी जी, तो 4 o'clock हमें वहां जाना है, तो आज नहीं करेंगे, फिर कल मॉर्निंग में।
Dr. Anurag, if you could mute yourself, we can hear your voice, please. Please mute yourself. Thank you. You may continue now.
Thank you. We need feedback from patients, and it is based on feedback that we have created all the other support systems. Support systems are very important, not merely for us, but also for patient groups. Every patient thinks they're unique. This pain is unique to them. That side effect is unique to them. But when they talk to others with the same disease, they realize they're not alone. So if they're able to talk to each other, that is a very important component. Communication, therefore, is one of the most important things that we try to build. We have a healing center, a rehab center, which we call Prashanti, and we offer practical aid in the form of prosthesis and bras for mastectomy patients, eye prosthesis for children with retinoblastoma, and any other kind of support that they might require. A good home-cooked meal is also one of them. So I think we have used our resources which are thin on the ground, but very deep in our concern to the best of our ability. And that is how we see ourselves going forward. Thank you.
Thank you, madam.
Thank you, ma'am. And next, I would like to come back again to Dr. Susanta Swan from SNO from Orissa, because when we are going to do this implementation, we'll be doing it in many district hospitals, many of which will be in the rural and underserved areas. So how do we ensure staffing of the physician and the pediatrician, and also put them on capacity building and the medical officer to do an extra work of chemotherapy? What are the kinds of incentives and professional career opportunity could be given to them so that they continue to work there and stay there to serve the public? Dr. Swan, your opinion here.
Sir, first of all, the selection of medical officers and nurses for the training and getting motivated, they are interested and willing candidates. And only incentives does not mean always that financial incentives will attract them to stay in a district headquarters instead of a state headquarters. They enjoy the work. The people we select, those people, they express their willingness or interest. They're interested to do this work. And they, after this 4 years of experience, they are not now much sought after. They're being respected as the oncologists of the district. So they're enjoying that. And that gives them a lot of respect, and they get phone calls and they mobilize and they have contact with the oncologists sitting in the tertiary care hospitals. They also facilitate the patients to go there and bring the drugs. If the drug is not available, they get it from the tertiary care itself and mobilize. They are a respectable person. They enjoy that. Incentives, whatever incentive, we have a plan in the Odisha. We have Odisha Comprehensive Cancer Care Plan. We had an incentive, small amount of 7,000 rupees per medical officer, 3,000 rupees per a nurse from the Odisha Comprehensive Cancer Care Plan with a recurring budget. But it will never attract them 7,000 rupees to stay in the headquarters. But one thing we can do, if they're trained, we can retain them, sustain them in the district headquarters. They enjoy the position of the medical officer over there, and that can also motivate. And career progression, like after they're trained, they can be given, suppose they're promoted to some other position, they should be, we should try that they should not be transferred out from that position so that we can keep it sustained. So these will motivate them. And the nurses, they find it, they also, because 2 to 3 patients a day and 8-hour shift, this is not a large, huge burden upon them. Most of the people who are not much mobile, not go upstairs, downstairs always, they prefer this job of daycare chemotherapy. And this, they can also take care of the, suppose some chemo pots are there, those patients are also coming to the facilities. They take care of those chemo pots and other things. They develop the skill. And some of the medical officers we discussed, they can also train other medical officers in the daycare centers also. They have so much confidence with them. And career progression, respect, and retaining them, not getting transferred out from the district record, that is motivating them, what we have observed, instead of financial incentives or something else. And these people, some are MDMS, MD in general medicine, some are dentists, some are pulmonologists. They are taking care of them. Okay, and we have a guideline published for daycare chemotherapy center. We have a definite guideline. They follow it up. There is a definite treatment protocol and which are the patients, what to do, what not to do. They're abiding by the guidelines we have provided to them.
Thank you, sir. Thank you very much. Thank you very much.
Thank you. Now, next panelist is Dr. Kalpana from Adyar Cancer Institute. Madam, could you please tell us something about strategies for effective linkage between daycare center and tertiary care center?
You are
Hello,
entering.
good afternoon. I'm sorry. This was what was this question about? Linkage,
linkage between district daycare center and tertiary care center. How to hub and spoke works.
Okay, so basically the district, the tertiary care center should be having the know-how for every, whether it is chemotherapy or palliation or for screening or for prevention and the IEC material. All of them, the tertiary center will have the material. So from there, they would have to give the details to the district headquarter hospitals. Like it was already mentioned, the details, they need to come and get trained in the tertiary cancer centers for about 2 to 3 weeks. And there has to be a continuous management of between the tertiary and the various spokes. The one way of doing that would be the telemedicine that is easily available today. And if each of the district centers have the capability of telemedicine from inception, then it becomes easy to maintain that spoke in the best way. And it is essential that the person at the hub is also knowledgeable and willing to listen to all the requests from the many spokes that are there. So that would also be an essential need. One of the things that I feel is when we are trying to get these district hospitals ready, we have to be very much aware of the what is needed. If it's going to be a 6-bedded unit, it doesn't make sense to have 20 monitors, or doesn't make sense to have. You have to have the capacity that is needed for that place, and not have a huge infrastructure which probably is going to drain you much more because of the continuous requirement to maintain it. So that is also something very important. And the other thing that would be important is to always not look at these centers as a standalone tertiary care cancer center, but as an area from where prevention, which is already spoken about, prevention is happening, palliation is happening, some drugs are basically there, and screening happens, basic HPV tests can be done. So all of that have to be, once it's integrated, it becomes cost effective too. So it is very, very important that all of these are integrated, and the training, the SOPs that are needed in the, which need to be made already, and most of them are already there, the tertiary cancer centers, need to be taught to the hubs, many the other district cancer centers, so that they can go on seamlessly. It was also spoken about the importance of, the ensuring that people in the area who are working in the district cancer centers are very happy with what they are doing. The employment engagement and ensuring that they're comfortable would also be, which is again spoken about, both in counseling and in giving them incentives was spoken about. That should also be something that we give a lot of importance to, so that sustainability becomes is possible. So that would be it. Thank you.
Thank you, madam.
Thank you very much, ma'am. And now, next panelist, I would like to come to Dr. Rizwan Quetta from the Quetta Foundation, and he also happens to be the chairman of NABH. Dr. Rizwan, our question to you is, suppose we are going to have the DCCs, many of which will be in remote locations. How do you envisage leveraging telemedicine in hand-holding these districts with the tertiary care institutes in terms of diagnosis, in terms of continuation of treatment? And also, I would like you to speak something on how do we maintain quality cancer care in these hospitals.
Sure. So first of all, thank you very much for giving me the opportunity. This is a really impressive initiative of the Ministry of Health, and I wish you all good luck. Wearing two hats in my feedback to you. One is as the chair of NABH. I would like to mention that this initiative is of acute importance to NABH. NABH already has a MOU with the National Cancer Grid, and it will be interesting for you to know that we are actually developing very specialized standards for cancer care, in addition to a lot of the general good standards that NABH has built over the last 20 years. And many of the standards that we are building in cancer care will be relevant for us to create opportunities for guidelines for the daycare centers as well. So we would love to engage with the ministry and develop very specific quality guidelines for the daycare cancer centers. And not only can we create those specialized guidelines as NABH, but we can also We have a very strong 3,000 member team of assessors. We can create a joint assessment program as well in conjunction with the ministry. Because one of the most important success factors for this initiative is going to be that over 750 plus districts in the country, how do we maintain a very consistent quality and consistent set of guidelines? And I'm very happy to mention that as NABH, we will be more than happy and excited to play the part from our end there. Wearing my foundation hat, our foundation works very closely with the National Cancer Grid, which is led by Dr. C.S. Pramesh, who also runs Tata Memorial Hospital. And through the work that the National Cancer Grid and our foundation have done, over the course of the last several years, we have developed very strong guidelines for electronic medical records and other clinical systems which are required for cancer treatment. And in fact, there are a whole bunch of open source guideline documents that have been published by the National Cancer Grid related with the use of electronic medical records and other, whether it's chemotherapy, medical oncology, others in the context of cancer. And the National Cancer Grid would be very open to creating specific technology requirements for the daycare centers, to ensure that the products that are going to be used for capturing patient data at the point of care are compliant with those standards. The next thing that we will be very happy to contribute is the National Cancer Grid has a network of 320 tertiary hospitals across the country. And these are some of the best known institutions for tertiary cancer care across the length and breadth. And opening that network of 320 tertiary centers for providing continuity of care. Continuity of care can be provided either through a telemedicine platform, and that could be done as well. Continuity of care may in some cases also require the patients from certain districts to then be referred to government, trust and other hospitals in their vicinity. And the entire network that has been built by the National Cancer Grid will become relevant for continuity of care and transferring patients from the daycare centers to other locations in a manner where not only are the patients moving, but also their records are moving in a seamless manner there. So all these things are, a lot of it is already done, but we as a foundation as well as the National Cancer Grid would be really excited about supporting the development of the clinical tools and the software needed at the daycare center, as well as supporting the operationalization of the telemedicine platform or the teleoncology platform that will be required for the success of this initiative. Yeah. So with that, I'm going to pass it back to you all. Thank you very much for giving us an opportunity, and look forward to positively contributing to the success of this initiative. Yeah.
Thank you so much, sir. Thank you very much for sharing your thoughts.
Thank you, Dr. Rizwan. Now, my next panelist is Dr. Deepak, Director, Acharya Harrier, Postgraduate Institute of Cancer. Dr. Deepak, I want to know about the feasibility of transportation, patient transport services. Do you explain through an example you have experienced in the field?
Good afternoon, everyone. At the outset, thank you very much for having me on this very eminent panel in pursuit, I think, something which is a very noble, a very novel venture. I think I realize that most of the speakers are speaking of a vision, whereas by virtue of my designation, I am indeed fortunate that I'm at the helm of facilitating daycare cancer therapy for the last 7 years in 30 districts across the length and breadth of Orissa. So as I understand it, the basic aim of the daycare cancer chemotherapy center is to act as a link between our tertiary center and the rural population who otherwise are unable to avail or have access to these facilities. Pursuant to this link, we need to now ensure that this patient is able to reach the daycare. Otherwise, the whole concept of the daycare would be futile if that poor patient at the periphery is unable to reach the daycare. So towards this, we need to facilitate some kind of transport arrangement to get him across from wherever he is in the rural setup to the daycare cancer chemotherapy. This, I would think, needs to be done in the kind of transport would be dictated by the topography, by the demography, by the population, by various aspects. In principle, it would, I think, entail transport, say in the morning, one shift at about 9 o'clock and an afternoon shift at 1 o'clock, which from the daycare does a round of a designated, delineated area, picking up all the cancer patients in that area and bringing them across to the daycare to facilitate not only their chemotherapy, but also act as part of our early detection, awareness, and various other programs that we hope to use the daycare to propagate towards cancer care. These same patients, having completed the treatment, could be dropped back at 1 o'clock, and the transport would then bring back the next afternoon bunch of patients for their daycare chemotherapy and the other aspects of cancer care. Ambulance requirements are not specific to cancer. They are for health in general, and the daycare would have the infrastructure to pick up patients from the periphery by an ambulance, and also when need arises, send them across to the tertiary care center for further care. So the essence, I would think, is in having a conveyance to bring the peripheral patient to the daycare to pursue our concept of making the cancer care more easily accessible and therefore more compliant with our needy patients. So that's the way I would look at it briefly. Thank you.
Thank you, Dr. Deepak.
Thank you, sir. Now, our next panelist is Dr. Moni Abraham from the Karkinos Foundation. Dr. Moni is the medical director of the Karkinos Foundation. He has been engaging in many PPP models of running cancer hospitals across the country. With your experience, Dr. Moni, could you explain what could be the possible role of public-private partnership in implementing these district cancer care centers, the daycare centers that we are going to have in the district hospitals? What could be the challenges? What could be the opportunities? Kindly share your thoughts on this.
Thank you, sir. Good afternoon, madam, ladies and gentlemen. It's a great honor for us to participate in this discussion. When we are talking about sustainability of this district daycare cancer center, we are talking about sustainability both in the operational as well as financial side, and definitely public-private partnership, NGO, as we heard from Indian Cancer Society, as well as CSR, will play a significant role. I work for Karkinos Healthcare. During the last 4 years, we have established 80 community cancer clinic. They are similar to the district daycare centers which we are talking about. And these centers are established in 7 states, mostly in L2, L3 cities. And these are established in a cluster fashion in which the comprehensive cancer center plays as a hub, and the community cancer clinic plays as the peripheral centers. Now, these centers not only provide daycare chemotherapy, in addition, they serve for diagnosis as well as supportive care. And these centers are forwardly integrated to the comprehensive cancer center, provide to offer comprehensive cancer care. But I must point out that almost over 50% of the cancer care could be delivered at the community cancer clinic. And backward, it is integrated with the primary health centers as well as NGOs for early detection and other supportive care. I just want to point out that currently the screening can be done only in about less than 2% of the population, but with engagement of NGOs as well as other entities, we can expand that. And these kind of early detection can be supported by a CSR type of initiative. And our workflow start with the risk evaluation in the community, and using the command center, we navigate the patient from the community to the community cancer clinic. And then at the community cancer clinic, diagnosis happens, and with using the virtual tumor board, make the decision about what the treatment needs to be done. And with the guidance of the comprehensive cancer center, we can extend that treatment in the community cancer clinic. As I mentioned, over 50% of the cancer care could be done under the guidance of comprehensive cancer care in the community setting. Now, when we operationalize this kind of concept, three strategies we use, similar to what other speakers have mentioned. Training is extremely important. We work with a CSR initiative, work with NGOs, and then use the existing infrastructure to establish the community cancer clinic rather than starting something on our own. So our suggestions are threefold. One is use the private sector wherever it required to establish the district the daycare cancer center. As we heard from Dr. Rizwan, there are large number of comprehensive cancer centers are there in both the private and public sector where there are no the comprehensive cancer centers work with the National Cancer Grid and provide that service. And third, make use of the CSR initiative primarily for early detection and the supportive care. And finally, tech platform, I cannot overemphasize the need for tech platform for integrating the entire care. I will pause here and happy to take any questions. Thank you.
Thank you very much.
Thank you, Doctor. Now again, we come to Dr. Chawla, Dr. Kalpana, madam. Can you please tell us about financial sustainability while maintaining the affordability of the treatment regarding the perspective of the patients, including healthcare schemes and insurance schemes?
Yeah, good afternoon again. So basically, for financial sustainability, two things would be needed. One would be, you want to see how much is the revenue, and that depends on the model that that is going to be there. It would be depend on whether it is going to be with how much the government is spending as it's a district hospital, and how much the other stakeholders and the patient is going to pay, how much of insurance is possible on all those things. So those would be the depending on that. So basically the cost that will be happening would be the patient cost for the treatment itself, the cost in the infrastructure maintenance, the AMC for the equipment that they spoke about, the housekeeping, the electricity. And again, these, when it started to plan, if you use environmentally friendly and you go ahead and start having solar systems upfront, the ongoing per monthly cost can come down. And the tertiary treatment plants, if they are banned for flushing, the water use will come down, and many of those things can be implemented from the in onset itself, so that's possible. And like I said before, having 2 or 3 centers together would certainly, working the prevention from the same place, palliation from the same place, and the daycare center from the same place, definitely helps in decreasing the cost and maximize the efficiency. So that would also be there. So when we talk about the expenses would be mainly for the drugs. So that would be a major cost of for the patient, and the expenses towards the other maintenance and the staff salaries. Staff salaries are going to be a big cost. Again, when we use the same staff for multiple things, that is one way of decreasing the cost. So everything would depend on the model and how big planning it is. So that's what it will depend on. Thank you.
Thank you, madam.
Thank you, ma'am. And now, next panelist, we would like to come back to Dr. Gerard, who is the State Nodal Officer of Tamil Nadu. Dr. Gerard, you are already very aware that we already have under the NP-NCD program, the National Program for the NCDs, that we have population-based screening for common NCDs, including 3 common cancers of oral breast and carcinoma, oral breast and cervical cancer. Now, while this screening is happening in the ground, if we diagnose or if we even say that you are suspected to be suffering from any of this cancer, there is a tendency for the patient to directly go to the tertiary care institutes, even to the level of Tata Memorial or all the Institute of Medical Science, etc., even skipping the medical colleges in between. So, in your practical experience till now, how do we address this integration of the existing cancer screening and prevention program with this coming up daycare centers that we are proposing to expand now? Dr. Gerard, we want to hear your thoughts here.
Thank you very much for this question. So we are looking at the daycare chemotherapy center as one point in the spectrum of care we give for the patients. So like we have to look at it in the context of the care pathway, the cancer care pathway or the continuum of care. That is how I think every state has to look at it. Only then we can understand the dynamics. What is very important is it is not only the daycare chemotherapy, but it starts, suppose we take it from the point of screening. So from the point of screening to your tertiary care, the strengthening of the primary, secondary and tertiary is very important. So I think the states take up in a phased manner all the districts in their own, under their health system to develop it in such a way that patient care for the cancer is properly streamlined across the 3 levels of healthcare. Without achieving that, it will be very difficult to retain your patients. Till that time, you will have always all the time patients going to some center which is popular. Second point is from the primary to secondary to tertiary. Sometimes it can be primary to tertiary. It depends on the location of the facilities. And once especially the IN treatment, whatever treatment is available for the common cancers, once we fill up we plug all the gaps, then even a model district can be taken up across the country. So in a model system, you will be able to show evidence by strengthening the system and addressing the gaps in such a way that there should be a referral forward and backward. That is what is the successful model can be. Other important point I want to highlight is the line listing of patients. Once you line list your patients, you will have a data. Whether it is your state-owned portal or Government of India NCD portal, you should have the line list of patients. But where the problem comes is how you integrate your portal, whichever portal you have, with your HMIS. So the ideal way would be you should have your hospital cancer registry developed. Even the states can take up their own initiative to develop the hospital-based cancer registry, which will have all the details of your patients, and the flow of information from there to your portal is one way. If the hospital-based cancer registry is taking time, still the HMIS of the state should be the viable clinical platform from where the data should flow to the cancer portal, whichever we use, the state or the GY portal. So the cancer portal, once we get this information, we can provide community care. That means patients go from screening point to the tertiary point. Then they need the community care in terms of palliative and physiotherapy. So Tamil Nadu model of this Makkaletedi Marthum, which we mentioned earlier, we have this concept very important that cancer patients need palliation, cancer patients need physiotherapy. So that community part of the care is also very important in this integration. So if we focus on the care on this aspect, then it is not only the strengthening the medical and the other aspects, the surgical, medical, surgical and the radiation aspects, not only that, but also the community aspects once they come back to the community and again when they have to go back to the tertiary care. So I think the whole spectrum of cancer care has to look at this in a larger sense. According to the provisions and the strength of the system in each state, we can move towards it. It can be a good vision to move towards. That is my view. Yeah. So yeah, that is what I thought I should summarize. This is the focal point which should be there as the final point to move towards.
Thank you, Gerard. Thank you very much.
Thank you, Gerard. Now I move to next panelist, Mr. Prashant Mathur from National Center for Disease Informatics and Research, ICMR, Bangalore. Dr. Prashant, I want to know about the cancer registry. Please explain us how data management and linkage with the registry will be done in district daycare center. How this data we can use further for the treatment and policy making regarding the cancer.
Yes, good afternoon, everybody, and thank you for this opportunity. The National Cancer Registry Program has been running since 1981 and continues to collect data on cancer from patients attending more than 7,800 sources across the country. This initiative of DCCC will be another very advantageous position to bring the data sets closer to the community, because today the cancer registries are mainly run in tertiary cancer hospitals, in public and private hospitals. This will enable evidence-based cancer care and planning at the district level. The taking district as the unit for the registry and analysis, the requirements would be to have a registry set up in each district by listing all the hospitals, health facilities, laboratories, hospices, palliative care center, etc., or anybody who is involved in diagnosis and treatment and related services of cancer patients in the district, both in the public as well as the private sector. And these should be recognized as data sources. And should be linked to many other databases in the district level, like the NCD portal, the routine HMIS, the death registration. So it is just not enough to count the number of cases of cancer occurring. It is also important to count those who are dying and why are they dying. So MCCD will be an important component under this. Linking of insurance and other beneficiary schemes, pharmacy, etc. The data abstraction will be on a standard form, which will be brief to capture essential information. And this should be linked to the Aadhaar ID and any other relevant IDs, because patients will move from one health facility to the other across districts, across states, across the country, and that we are unable to control. So, but if we have a unique identifier linking this, we can, keep track of these patients. And dynamic data aggregation and analysis at district, state, and national level. Our key objectives should be the coverage, completeness, accuracy, and validity of the data. And for this, we need to build a lot of capacities in data management, analytics, and more importantly, in the utilization of this information for monitoring the cancer care and decision making. Providing dashboards which will provide information for monitoring as well as for advocacy and community engagement will be another aspect of daycare cancer registry. The outputs we expect are there. So there are more than 100 sites of cancer where cancer can occur in the body. So including the pediatric age group, women and elderly. So we can generate statistics related to burden of cancer disaggregated by age, sex, give trends, treatment, survival, deaths, and also projections for cancer. But most importantly, we can actually measure and monitor the quality of cancer care being given and strengthen evidence-based treatment, which will be there. Also, this will be a useful tool for measuring continuum of cancer care, so that when patients move across facilities, their cancer care is not disrupted. And also this will be able to capture, today we are suffering from access to care as a major challenge, because we are seeing 3/4 of cancer as late stage cancer. Linking this to other cancer prevention and control efforts at the district level will be an important outcome of cancer registry. Assessing impact of public health actions, most importantly, cancer screening and risk factor reduction initiatives. Most relevant outcome as in people will be to empower citizens with appropriate information and improve community engagement at the district level. And this could be a very important tool for actually evaluating the whole DCCC model to see how effective it has been in delivering affordable, equitable, and high quality cancer care. So thank you very much.
Thank you, Dr. Prasad, for that effort on highlighting all of us what the cancer registry is doing and how effectively we can link it. Now we would like to come back to Dr. Anurag Srivastava, sir. We all know that cancer is multifactorial. There are so many causes of cancer. It is an aging disease. As we grow older, we have more tendency of having disease also. But we also say that the best management of for cancer is not to have it at all. So, sir, we would like you to speak on how do we prevent? What are the ways and means of preventing cancer from happening in this body? We can't do for all cancer, but for some cancers we can still prevent them. So, would you please speak on this area and highlight that for us?
So, about 40% of all cancers in India are tobacco related. So, tobacco control with tobacco cessation units, stricter control of tobacco sale, especially the chewing tobacco. You know, there is no prohibition on the sale of pan, parag, gutka and other, chewing tobacco products. So stricter control on tobacco sale, especially the chewing tobacco, control on supadi, betel nut. Betel nut has now been proven by IARC and other experts to be a definite class 1 agent for cancer causation. So control on tobacco, control on betel nut, supadi, and control on alcohol. Alcohol, along with tobacco, has a synergistic action on causation of cancer. So again, and in itself can cause cancer of the GI tract and the liver after cirrhosis, hepatocellular carcinoma, etc. So alcohol control, tobacco control, betel nut control, and then as Honorable Prime Minister mentioned, emphasis on yoga and pranayam. So that will again go a long way in controlling the diet control is very important. So regular proper diet, especially emphasis on fresh fruits and vegetables, the millets, and control of obesity, control of diabetes. Diabetes is related to occurrence of increase in incidence of cancer. So control of proper diabetes, control of obesity, and Honorable Prime Minister has initiated the Khelo India and Fit India programs. So they are wonderful programs. And studies have shown that if the young girls get engaged in vigorous sports activity and physical activity, they can delay the menstruation, and delay of the menses in young girls can prevent breast cancer. Studies have shown that. So Khelo India and the Fit India program can go a long way in keeping all the lifestyle disease related diseases like diabetes, blood pressure, heart attack, cancer, stroke, obesity. Everything can be controlled if we engage our children right from the start on Khelo India and Fit India, proper diet, control of fat intake and fried foods, control of tobacco, alcohol, and regular sleep pattern. Also sleep. Studies have shown that those who work in the night shift have 3 times increased risk of breast cancer compared to those who have good night sleep. So regular sleep habits and lifestyle will go a long way in controlling all these diseases. Thank you.
Thank you very much, sir. Thank you very much for throwing a light on that area. Now we would like to come to Madam Dr. Susma Bhatnagar. We were talking about prevention. We were also thinking about expanding the services of cancer care, including the daycare centers that we are discussing today. But despite all these efforts, there will be certain population, certain portion of the population for which we are not able to give them new life. We are not able to cure them from the cancer. So, but we have to provide quality care for the remaining years. So we are talking about the palliative care, ma'am. So, ma'am, we would like you to speak more about how palliative care can be effectively integrated to the daycare centers that we are seeing, leveraging all stakeholders.
Okay, thank you very much, Dr. Swastik. Actually, my video has suddenly stopped. I don't know what is happening in video. So I just want to say that we have, recently we have started a palliative care program in 100 districts of northern part of India. And what important thing which is that, because this is now there is no need to say that in our country 60 to 70% patients, they present in advanced stage and they are in pain and symptom, they are having severe symptoms, and this can be treated right at the doorstep if we will teach and train doctors and nurses. So there are ready modules for doctors, there are ready modules for nurses, and we can teach them that how to take care of pain, how to take care of the symptoms, how to, as I told you before, how to take care of many oncological emergencies is basically palliative care. So we have to teach them that how to take care of all these palliative care emergencies. And always palliative care is a multidisciplinary approach, so it should be in the real sense multidisciplinary. So doctors are important to teach them, but nurses are basically the backbone. So we have to teach and train nurses a lot. If we will teach and train nurses, most of our half of our the training and teaching will be definitely go in a right direction if we will teach and empower our nurses. Then one important thing which we have to teach and train our nurses, that when patient is going home, how to empower them that they can take care of patient at home. Most of the time patient doesn't want to go home because they don't feel empowered, that how will I take care of my patient at home. So how to look after the wound, how to look after pain, how to look after the other symptoms, so all these things. So we have to teach and train that how to look after the patient at home by mainly by nurses, but definitely there is a role of doctors also. Similarly, physiotherapists, those are available in the daycare centers. We have to teach and train in just a slight more skills, how to take care of lymphedema, how to take care of patient who is having breathlessness, how to give them a respiratory or physiotherapy, respiratory physiotherapy, so that they can feel better. So our aim will always remain to improve quality of life, and to improve quality of life, we are going to teach and train all these people. So, one more important thing which we have to in palliative care setting, we have to teach our pharmacists. Most of the time in district 100 district, what I have seen that not like in almost in 80 districts there were pharmacists available, but they were not having enough knowledge of safe procurement of opioids, how to procure, how to store, and how to dispense, and what are their responsibilities. I have seen in a biggest hospital of this Delhi hospital, when it is not available for pain management, how can we expect that it will be available in 100 in the daycare center? Till the time we will not tell them. So we have to tell them that how it is an important drug, essential drug for pain management, and it should be available. And but when it should be available, how it will not be misused. And as Dr. Srivastav and Anup, Dr. Anurag Srivastav has said that there is a lot of role of non-pharmacological therapy like yoga, pranayam, but definitely when patient is in pain and symptoms, they will not be able to do. So first we have to relieve, and then we have to teach and train all these non-pharmacological therapy. I hope I have answered your questions.
Thank you, ma'am. Thank you so much for comprehensively answering that. We have taken care of the patients, how to prevent them. And those people who are not, we are not able to prevent, we have got a scheme, we have got arrangement for making the treatment available near to the doorstep. And we have also taken care of the palliative component for those patients whom we are not able to cure them of cancer. But the other remaining challenge that we have is, say for example, a cancer patient goes through the journey. The whole family goes through the journey. Now he has survived, for example, he or she has survived the cancer, but during the process of getting treatment, he has lost his job. So how do we ensure the cancer survivorship? This is a larger question, but very difficult to answer. But I would like to pick Dr. Deepak. Would you like to have your thoughts here on this area? Dr. Deepak.
Yes, thank you. I completely empathize with your question. And when we address cancer, it's not just the patient that we need to address, it's the caregivers and support system. And they all are part of it in that they incur a lot of financial losses, they incur a lot of hardships, and they incur a lot of social ostracization also because of the lack of awareness. So look at this in totality. And insofar as we have schemes where the cancer patient is rehabilitated, he gets appropriate certification of his disability and he is reinstated to the best of his ability. But addressing your point further, I think we should also look at certification of the relatives being that of a cancer patient, and therefore entitling them to some job leniencies. So that I think would definitely, wherein the government needs to come in, just as you give a concession certificate in the train or in a bus for a cancer patient to go with one attendant. So similarly, you could give job reservations for not only the cancer patient, but also one relative. So that could be worked upon, and it would definitely address an unmet need of cancer care in this country. Thank you.
Thank you, Dr. Deepak, for throwing light on that area. We have taken the comprehensive aspect of health promotion by means of healthy living, preventing cancer as much as possible, along with the NCDs, and also providing treatment to the patients who are already suffering from it, and also covering the palliative component of cancer care and cancer survivorship we have discussed a bit today. Ma'am, we would like to end the webinar here. We would request you to provide the closing remarks and thank the panelists.
On behalf of the Ministry of Health and Family Welfare, I would like to thank all the esteemed speakers and subject experts who have delved upon this topic of how do we strengthen, how do we establish daycare centers in district hospitals, as it was announced in the budget of this year. All the experts have on various phases, like the challenges that we are facing in establishing these centers, how do we properly establish these centers, and which are the various areas which we need to focus upon, keeping in mind the continuum of care chain, also the patient's perspective, the transport perspective, drugs, diagnostics, HR, which is the most important resource for us. The entire holistic approach which is required for establishing the daycare centers. I think all the experts have given their suggestions, all have been noted down, and then we would work upon this, the ministry would work upon this in details and prepare a clear timeline for execution of this program. Thank you all once again on behalf of the Ministry of Health and Family Welfare.
Thank you, madam.
Thank you.
Thank you.
Thank you, madam. Thank you, madam.
Thank you.
Thank you. Thank you very much.
Jyotsna madam, namaskar. Jyotsna madam, namaskar.
Namaskar and thank you. Nice to see you.
Nice to see you. Nice to see you so well, smiling as ever. Thank you, thank you. Thank you for your inputs.
So I'll request all the panelists to please stay on because there are further sessions by various secretaries of the various ministries as well as the honorable ministers of the ministries for the closing. I'll request all the
Request all to please mute yourself. We can hear some voices. Thank you.
You are entering the meeting now.
You are muted. Can you say something?
He can't speak.
Hey, we are not able to hear.
I can hear you, sir.
Camera on. Hello, I think our audio and video are coming perfectly.
No, my audio video is coming, but I was listening to Professor Kamakoti, whether he's not there because he has to give a presentation.
No, we can hear him now.
Yeah, we can hear him.
We can hear him.
Yes, sir.
You are entering the meeting now.
Which was there under the Department of Higher Education, was on COE in AI for education. The discussion included developing a detailed roadmap for operationalizing the announcements, including timelines and key milestones, and establishing clear guidelines on regulatory frameworks and compliance requirements. Comprehensive strategies for integrating AI and skilling programs into mainstream education were highlighted, along with the best practices for curriculum development and teacher training in AI. As far as the experts who participated in this, they also represented various regions, and there was good sectoral representation from academia, 11 experts, industry leaders, 3 experts, and government officials, 3. In terms of domain expertise, 6 experts were from AI and computer science. Engineering, there were 5 of them. Education and management, 4. And energy and sustainability, 3. State-wise spread was also noticed in the experts. They came from 8 states. As far as the recommendations are concerned, the group has recommended that immediate steps are required to integrate AI into education effectively, to ensure the model should ensure equity, access, inclusivity, and this should be at the core of AI adoption. Universities must embrace AI-based curricula and foster collaboration among stakeholders. Students must be actively engaged with, and they should be encouraged to use AI-driven learning methodologies. This is not just about the budgetary allocation. We must move from vision to implementation with a strong focus on preparing India's workforce for future. As India stands at a crossroads, we have the opportunity to lead in AI-driven education, and it was said that AI will be a crucial driver of India's growth towards Viksit Bharat, and we must seize this moment to shape the future of learning. The third breakout session under the Department of Higher Education was on expansion of capacity of IITs. The expected outcome of this session was to establish a clear implementation roadmap for the expansion of IITs, ensuring alignment with the Union Budget 2025-26 and NEP 2020 goals. As far as the experts are concerned, they represented 10 states and UTs. There was a good sectoral mix from academia. 8 experts were from academia, 2 from industry, and 2 from government, or they were the ones who were playing policy roles. In terms of domain expertise, 7 were belonging to engineering and technology, 2 were from science, and 1 was in security, data security and privacy, 1 was in disaster management, and 1 in skill development. And as far as the composition is concerned, the panel brought together voices from research, industry leadership, public service, and fostering a holistic view of the national development. The discussion emphasized the importance of engaging with stakeholders, including educators, industry experts, and community leaders, to build consensus and promote a collaborative approach. Potential challenges related to infrastructure, funding, faculty recruitment, and inclusivity were identified, and strategic solutions were proposed to overcome these obstacles. The need to strengthen research capabilities and foster innovation in emerging fields such as AI, quantum computing, and machine learning were highlighted. Additionally, the importance of promoting inclusivity and equity to address regional imbalances and provide increased access to quality education for underrepresented communities were underscored. A robust monitoring and evaluation framework was also discussed to track the progress of expansion projects, ensuring transparency and accountability. Short-term specialized degree programs to address the emerging skill demands was one of the major recommendations. Thank you.
Thank you, sir. Now I request Sri Anil Malik, Secretary, Ministry of Women and Child Development, to sum up the breakaway session on Saksham Anganwadi and Poshan 2.0. Over to you, sir. Secretary, Ministry of Women and Child Development. So, shall we go to the next one? Can I request Dr. Neeraj Mittal, Secretary, Department of Telecommunication, to sum up the breakaway session on broadband connectivity to government secondary schools and PHC? Now we have the WCD. So, yeah, I think additional secretary is there to sum up this. Yeah. Yeah. Over to you, Ganesh.
Oh, okay.
Sir, I think Secretary, Ministry of WCD is present, so I'll request sir to start. Sir, we can't hear you.
Okay, but
yes, sir. Sir.
Is it audible now?
Yes, sir. Now you are audible, sir.
Good afternoon. So this was the budget announcement the Honorable Finance Minister made. This was regarding cost norms. May I continue? May I continue?
Sir, please continue, sir.
Okay, because I can hear a lot of background noises. So the Honorable Finance Minister made this announcement in the budget, cost norms for nutritional support. This was for, Anganwadi system. Next. So this is just a brief of the whole Anganwadi system in the country. It's almost 14 lakh Anganwadis across all the states. And this is what we do. I think it's well known. The major 6 jobs, SNP and preschool non-formal education, immunization, health checkup, referral services. And we serve children, adolescent girls, pregnant women, and lactating mothers. Next. The numbers I gave in the morning, and they discussed in the afternoon also. This is one of the biggest beneficiary-oriented programs, 100 million total beneficiaries. Next. So there is this comparison also, before 2014 and after 2014. So a lot of strengthening of the Saksham Anganwadi, which was discussed in the webinar today. So some of the points are highlighted here. That smartphones, growth monitoring devices, they were not there earlier. And then the concept of Jan Andolan, Poshan Pakhwada, Poshan Mah, community-based events, they were not there earlier. There were a lot of so-called mini Anganwadis, which were pretty much dysfunctional. They have been converted into main Anganwadi. Then the concept of, drinking water and toilets in all the Anganwadis, it has been emphasized only since 2017. Then we are saturating the tribal areas, with Anganwadi system. Next. fortification of the flour and the ingredients and use of millets, concept of Poshan Vatika, where Nutri Garden will be established. More than 6.5 lakh, almost 6.5 lakh have been established. So all these things were discussed about the strengthened Saksham Anganwadi in the afternoon session. Then regional diet charts and these two protocols we discussed in the morning also, of management of malnourished children and management of Divyang children. Next. And the Anganwadi workers and helpers, they have been covered under Ayushman scheme now. And we are now emphasizing on the ECC part quite a lot, which was not there earlier. Next. The gender budget has correspondingly increased in last 10 years as a proportion of the total union budget also, from about 5.48 to 8.86 crores, 86%. Next. Go back. These indicators were also discussed that the rate of decrease in malnourishment is a little on the lower side. Though our tracker data is showing that that has picked up, and now the level of malnourishment is not that high as is being projected through the NFHS. Next. This is just one of the designs of a Saksham Anganwadi. We have approved 2 lakh right now. About 17,000 have already been established. And in the next FC cycle, we are going to approve more. Next. There was a discussion on the IT system Poshan tracker also, how it has changed the dynamics and the data, integrity as well as the data availability. It has also strengthened the beneficiary, vis-a-vis the Anganwadi worker, and also help the Anganwadi worker, reducing drudgery in her job. We are going to use it for further improvement in the delivery of services through facial recognition system and also popularization of the beneficiary module, so that the beneficiaries have more power vis-a-vis the worker. Next. The idea of convergence with the ministries was also discussed. We have, we converge our job, the items that we take up for implementation in the Anganwadi sector. They converge with the activities of these 17, 18 other departments and the Niti Aayog. So on and off, we keep on dialoguing with them, holding meetings with them and VCs with them. At the state level, at the district level also, there are committees to take care of the convergence. But this is an area which needs continuous monitoring and continuous hand-holding. It's not easy to achieve. Next. This is about pre-2014 and post-2014 situation in the idea of women-led development. Though this was not strictly discussed in the afternoon session because that was focused on the Saksham Anganwadi. But this highlights the commitment of the union government to forge women-led development by these initiatives like Nirbhaya Fund initiatives, focus on gender budget, the schemes like Emergency Response System 112, One-Stop Center, Women Helpline, next fast-track courts, then concept of anti-human trafficking units, women help desks in the police station, then strengthening of forensic science labs, and various other initiatives about crimes against women, how to investigate and speed up the investigation. Next. Then the concepts like Safe City Project and the scheme Beti Bachao, Beti Padhao, the database on sexual offenders, all these things, paid maternity leave, which was increased to 26 weeks. So these are and mandatory requirement of crashes in establishments having more than 50 employees. These are various measures that have been taken up, to promote women-led development. Next. These are initiatives taken by other ministries, permission to women in combat roles in armed forces, girls in Sainik schools, girls in NDA, and then women allowed to work at night and under certain conditions, reservations in CAPF, and all these other initiatives that are indicated here. Next. Next. So the key takeaways were that all the stakeholders and organizations, they have to come together, converge, and because the Saksham Anganwadi program is not merely of the WCD ministry. It deals with the development of human resources of a very sensitive group, where the brain development happens the maximum in that time. So the convergence and all other efforts, use of technology, and now the diversified diet for which the special budget allocation has been made, behavioral change at the society and at the individual level, then the idea of AAA, ASHA, Anganwadi worker, and ANM, they have to be effectively working together, and then the concept of scalability by involving private sector, international organizations in different initiatives. All these things were discussed. Next. Okay, I think that's about all about the summation of the discussions. Thank you.
Thank you, sir. Now I request Dr. Neeraj Mittal, Secretary, Department of Telecom, to sum up the breakaway session on broadband connectivity to government secondary schools and PHCs. Over to you, sir.
Thank you, Honorable Minister for Higher Education, all colleagues who are here. This was a very insightful and enriching discussion today with experts, policymakers, and stakeholders who came together to chart a path for using the rural broadband connectivity for secondary schools and PHCs under the BharatNet program, which has been announced by the Honorable Finance Minister. Special acknowledgement to sister departments of Ministry of Education and Ministry of Health and Family Welfare, all the agencies who would be working in this collaborative effort. And this seminar is one of the starting points to actually engage with all of you to be able to chart a plan so that the end users who are in PHCs and in schools really benefit from this wonderful initiative. In terms of the interaction which happened, there were a lot of suggestions, and of course, people foresaw that there will be a lot of benefits to the stakeholders. In terms of benefits for the education, the schools and the children who are studying there in the higher secondary schools, we foresee that the smart classrooms, e-learning platforms, access to quality teaching materials would lead to bridging of the urban quality can be brought to the rural areas of education. Teachers would also benefit from access to online training programs, AI-driven teaching tools, other digital literacy initiatives, enabling them to deliver better learning outcomes. We would also be able to possibly integrate Samagra Shiksha, Ullas, and other initiatives to ensure that every child, regardless of geography, has access to real high-quality education. In terms of suggestions which might be some kind of challenges which you need to deal with, would be to actually enhance the digital literacy, provide good quality content, maybe see how the next technologies such as 5G and 6G can bring AR, VR, high bandwidth technology to the schools to improve their uptake of knowledge. How do you provide support in a 24/7 initiative to all the large number of schools and students? Access to digital devices, both at home and as well as in schools, and possibly some kind of a language divide which might hamper the absorption and access to these programs. On the healthcare side, it was discussed that the telemedicine will bridge the healthcare gap for rural populations, allowing remote consultations, digital prescriptions, and better disease management. Electronic health records under the ABDM would ensure that patients have seamless access to their medical history and provide them a better level of healthcare in their homes in rural areas. Platforms such as eSanjeevani, Telemanas would also enable real-time medical assistance diagnosis and bring tier 3 best quality medical care to the doorsteps of rural patients. This, of course, there are some challenges which we have foreseen. Again, Some of them are relating to digital literacy, of handling, this kind of platforms in rural areas. Another challenge was, since these may be dependent on high bandwidth requirements, the consistency and quality of the BharatNet would be something which we have to be ensured. Capacity building of the PHC staff would be another challenge, and the use of concomitant digital infrastructure such as the ABDM would really bring benefits to everybody. This is not about just building digital highways. It is about building a stronger and inclusive India. And therefore, the bridging of digital divide, empowering of rural workforce, strengthening governance and service delivery in these areas is something that this project will deliver. We need to collaborate with our government stakeholders, educational and healthcare institutions, and community involvement. And we look forward with all the suggestions which have been received today to take it and make the Prime Minister's vision a success. Thank you so much.
Thank you, sir. Now I request Sri Atul Kumar Tiwari ji, Secretary, Ministry of Skill Development and Entrepreneurship, to sum up the breakaway session on National Centers of Excellence for Skilling. Over to you, sir.
Namaskar, Honorable Minister for Education, Honorable Minister for State, Independent Charge, Skill Development and Entrepreneurship, my colleagues, secretaries, and all those people who have joined on this webinar. Sir, first of all, I'd like to highlight what the Honorable Prime Minister said initially in his address, which was that the investing in people provides the roadmap for a Viksit Bharat, our vision of Viksit Bharat. And he also laid down there three pillars critical, which is education, skilling, and healthcare. Then he also mentioned that how many people have been trained and the upgradation of ITIs have been taken. And he emphasized that it is necessary for us to train our youth in industry-relevant fields, bridge the gap between industry and academia, and industry and academia have to play a crucial role in skill upgradation. Sir, we had a distinguished group of panelists from the state government, from the industry, from the academia, and also from the international experts. And we also had a question-answer session. And the points, the various suggestions were made by the industries in how the Center of Excellence are critical for transforming the skilling ecosystem. Kya ho gaya? Yeah. So, and global partners also gave their suggestions as well as states and academia. So, and this webinar was also viewed by webcasts and VC Links, NCVT awarding bodies, assessment agencies, around 8,000 ITIs, NSTI, NIMIs, and apprenticeship JSS, and all put together, sir, we had almost total 12,642 people were there watching this session, sir. Sir, we have a small presentation in which I will just very briefly show you the key takeaways from the breakout session. Presentation, please. Aya? Yes. So this is the theme number 4 on investing in people, sir, in which the next slide, please. These are the National Center for Global Expertise, which was made in the budget announcement, sir. And this is what we say that this will be the where we like to go ahead, like the proposed features. How do you leverage global partnerships, research ecosystem, existing courses, and skill qualification framework, higher level. Next, please. And these were the panelists, sir, that from the state government of Odisha, Karnataka, and Gujarat, industry from Tata, sir, Reliance, and the J&K Siemens. From academia, we had the Institute of Competitiveness, and international, we had from the World Bank, sir, and 2 from Singapore. Next, please. So these are the detailed pointers from the industry. They say that the Center of Excellence are very critical for transforming the skilling ecosystem, and industry participation in training can happen through a revolving door mechanism so that the people who work in the industry as well as they also come for the skilling institutions. And they also wanted that there should be industry investment in skill development over and above the CSR funds which is required. They also emphasized that we need to have a special cadre for the master trainers, and whatever COE which we have, they should integrate digital infrastructures and advanced technology. Next, please. The global partners, in sum, they said, sir, that the collaboration with global institutions will enhance the course design. They also said the industry-aligned finishing schools may also be necessary to bridge the quality gap in vocational education. They also said that there should be intensive training of trainers much before they go for the local teaching. And they said that there has to be some mechanism whereby in lines of the what is happening in education, so continuous tracking of student progress, placements, and industry feedback. Next, please. The state level say that we need to revamp our ITIs with modern technologies like industrial robotics and EVs, and they wanted the COEs should function as knowledge partners for ITIs following a hub and spoke model. And they also emphasized that the public-private partnerships are essential for scaling the skill development, and there has to be certain autonomy given to Center of Excellence to introduce new courses aligned with industry needs, and the NSTIs should evolve also into finishing school for ITI graduates. Next. The academia's role in skilling was emphasized that the only a very small population of India undergoes effective skill training, and they also say that if we give them training, that increases their per capita income, and there should be sectoral focus on undertrained industries like agriculture, ITS, and manufacturing. And they also wanted that the foundational learning should be strengthened before taking the large-scale vocational training. That's it. So the key takeaways are, sir, that which is a mixture of all that, sir, that it should be industry-led governance. There should be a partnership with global institutions. The curriculum needs to be continuously upgraded. We should have a relationship with think tanks and partnerships. And the COEs could serve as a research and innovation hubs for the industry in terms of short-term training as well as and the curriculum design will be a very important aspect of which I have said. And they also wanted that the trainer should be taken from the industry on rotation basis, and there has to be some amount of standardization along with the autonomy and flexibility in introducing new courses. They also, a very important point which was mentioned was, sir, that if you are going for manufacturing, generally the wages in the manufacturing are not good. So in order to attract, we need to think in some possible ways in which we can have minimum wage support for manufacturing. So this sector becomes more attractive over and above the existing sector where all the youth want to go, sir. And of course, the focus has to be in digital infrastructure, for faculty exchange, high NSQL level courses, and focus on foundational skills. And the focus area should be identified. And they also mentioned which are the areas on which these center of excellences can focus on. And they very much emphasize that there has to be new age courses like data analytics and green skills, and there has to be continuous upgradation of curriculum to maintain industry academia partnership. That's all I have to say, sir. Thank you very much.
Thank you, sir. Now I request Ms. Punya Salila Srivastav, Madam, Secretary, Ministry of Health and Family Welfare, to sum up the breakaway session on expansion of medical education and day care cancer centers in all district hospitals. Over to you, Madam.
Yes, Sunil. I just have a small presentation which I'll share. So as Sunil mentioned, am I audible? Sunil, I'm audible, no?
Yes, ma'am, you are audible.
Okay. So, sir and dear colleagues, in our, as Sunil mentioned, our post-budget webinar focused on two budget announcements. One is relating to medical education and the other to cancer care. Our next. Our introductory session was spearheaded by Dr. V.K. Paul, who is member health of NITI Aayog. And in this session, he basically explained how in the progress over the last decade, we have laid a strong foundation for this year's budget announcements, both in the sphere of medical education as well as in the sphere of cancer care. So as Sunil mentioned, the first budget announcements relates to setting up of 10,000 additional seats this year in medical colleges as well as hospitals. And this is to achieve the goal of adding 75,000 seats in the next 5 years, which the Honorable Prime Minister had said in his speech on 15th August 2024. The challenges that were identified during the webinar primarily related to the shortage of qualified faculty and specialists, to affordability and accessibility of medical education, availability of adequate clinical resources as well as infrastructure, and it also spoke that there are limited opportunities for specialization, which leads us to a vicious cycle of not having adequate faculty. Next. Then we have tried to categorize the recommendations that came during the webinar into these broad categories. So as far as the faculty development and shortages were concerned, our experts who ranged from private colleges to government colleges to the regulators and very esteemed faculty were there in the whole session, which was managed by Director Ames. In that, the experts basically stated that we need to assess our faculty gap and ensure that the recruitment that we do aligns with the increase in medical seats which we are planning. So they thought of ways to expand the pool of faculty. They came up with a suggestion that maybe we can share faculties between medical colleges, especially with regard to non-clinical subjects. They also spoke of leveraging technology for teaching. Honorable PM also today in his address spoke of using technology for education. So this was a suggestion which came forward from our experts also. There was talk of strengthening of the faculty development programs so that our faculty can keep in tune with the emerging medical education, and this would bring in better remuneration and career progression for them also. So there was talk about flexibility in entry as well as in faculty norms. And in order to encourage research, they said that there should be adequate time available for research also to our faculty. And they spoke of having perhaps separate recruitment boards in states for faculty. Regarding curriculum, there was stress on competency-based medical education and bringing in early clinical exposure for our students. They also emphasized that the communication skills of our students and faculty has to increase. So bringing in soft skills into the modules, research skills, and we should not just emphasize the curative aspects, but also the preventive and promotive aspects relating to health. A lot was spoken on integrating AI, telemedicine, digital health into the syllabus. And there was talk of centralized digital libraries, tele-learning platforms, and simulation labs. A very important point which emerged from the entire discussion was that we need to optimize our existing resources, because that is the only way we can tackle the issue of resource crunch, both in clinical as well as infrastructure resources. It was said that we have district hospitals, we have smaller hospitals, we have hospitals belonging to public sector units, central government hospitals, we have the private hospitals. So how can all of these be utilized for medical education was discussed, and bringing in public-private partnerships to enhance medical education was also touched upon. Then regarding PG seats, it was strongly felt that we need to increase PG seats, and this could be done by leveraging some of these hospitals for bringing in standalone PG institutions. These hospitals could be of health ministry, they could be of the other ministries, they could be of ESIC and our various other PSUs. These could be private institutions. Another feedback which came from the state secretary was that we should implement the district residency program. Not only does it address, brings in clinical exposure to our students, but it will also help us bring in additional 25% seats. This came as a very good suggestion. Regarding affordability, there was talk that the regulation of fee structure should be done in a very fair and transparent manner, and we have to see how can we bring in more low-interest student loans as well as expand scholarship where required with the help of CSR. Based on these recommendations, a very tentative implementation plan has been drawn up. How states, during which timelines should states map the existing seats in their medical colleges? What is the possibility of expansion? Where can we start DNB courses, especially in private hospitals? Where other ministries can identify their potential hospitals where we can start PG institutes? A stakeholder consultation to meet the faculty requirements as well as faculty development. How to strengthen competency-based medical education. We decided to set up a core committee which would look into integration of AI, digital technology, and research in medical education. So these were some of the points and we tried to draw up an implementation plan for ourselves. The next budget announcement deals with setting up of daycare centers in all district hospitals in the next 3 years and 200 centers this year itself. For this webinar also, we had experts from every tier of cancer care, as well as those who are working with patient support groups. We also had people from the NABH, from other foundations who are working in cancer care. The challenges which were identified during the webinar, of course, relate to manpower shortages because this is a very specialized field. There was emphasis on the training needs, the equipment and infrastructure, if it has to be brought in district hospitals, how to go about it, how to manage the drugs, because there would be requirement of specialized drugs for every type of cancer, and the talk of referral systems, because as Dr. Paul had also mentioned in the morning, at primary healthcare level, we are doing screening for 3 types of cancer, how to link it to our district hospitals, then to the state cancer institutes and other tertiary care institutes. So the recommendations was that we need to ASAP do a gap analysis of all our district hospitals. The training programs have to be very comprehensive. Luckily, in our expert group, we had people who have developed such daycare centers. So they had a lot of suggestions to offer to us how standardized training modules can be developed, how do we train the existing staff and local doctors, and also ensure the availability of these trained doctors in the district hospitals. Honorable PM spoke in the morning about daycare centers and digital health infrastructure, linking the two. So this will, of course, prove very powerful because we are dealing with the poor population, which may also be migrant population. So we need to track them. So as another colleague spoke, it is very important to implement the Ayushman Bharat digital mission fully, and having broadband connectivity to our PHCs will help, because that is where the ABDM registration starts in most cases. There was also the talk of the importance of patient support groups in hand-holding the patients.